This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Halley Alexander with the Neurology podcast. Today we're going to talk about some very high yield and common genetic epilepsies in women. I know sometimes when I hear the word genetics, it makes me think of rare syndromes, but that is not the case, obviously. So this is some really clinically relevant information here today. Joining me today is Paula Marques from McMaster University. She's an epileptologist with special training in epilepsy genetics, and she recently published an article in Neurology Genetics on this topic. So tell us, what are some of the most common genetic epilepsy syndromes in females?
First of all, juvenile myoclonic epilepsy is a very common one that can be seen by many practitioners, not only in epilepsy centers, that could have a really good outcome. Then we're also going to discuss Rett syndrome. It is more rare, but can be seen mostly in epilepsy centers, as well as CDKL5 deficiency disorder, or CDD, PCDH19 related epilepsy, and Aicardi syndrome, and then some related to brain malformations, which are not usually thought of, such as subcortical band heterotopia and periventricular nodular heterotopia.
And then for something like JME, or juvenile myoclonic epilepsy, why is that seen more commonly in females?
The incidence overall is just slightly higher in females, so it can occur, according to some studies, like 60% in females as opposed to 40% in males. The other important point here is that it's more frequently transmitted to offspring by affected mothers than by affected fathers, which is not well understood, actually, not related to X. The reason for the sex difference in IgE, so again, it's not well understood, but could be related to the complex interaction between genes, environment, and importantly, female hormones, which play a big role in epilepsy in females. Juvenile myoclonic epilepsy, it is one of the most prevalent idiopathic generalized epilepsies, and therefore is more known for a lot of practitioners, which is why it's important to understand how genetics plays a role here.
And you mentioned that it's, not entirely understood, the genetics behind JME, but do they have any idea what genes might be responsible?
So there are very rare cases of what we call familial juvenile myoclonic epilepsy, which is less than 1%, which would be inherited in a Mendelian fashion, which means the risk could be between 25% if it's autosomal recessive or 50% if it's autosomal dominant. So some genetic mutations that have been described are in genes like EFHC1, CACNA B4, CSR, GABRD. So there are a lot of big names for genes, and there are a few others that have been found. But what we usually see that has been something known only recently is that the majority of cases are what we call a complex genetic inheritance, which is a little bit more difficult to understand. But what it means is that there are several variants, which are not necessarily one affected gene, and they have small to modest effects and will contribute to the risk or susceptibility and to its complex genetics. It's something we see in other conditions, even like in schizophrenia, for example. The implications of this are that to inherit JME is hard to estimate.
It comes up a lot that we're doing counseling on reproductive issues because they're often of childbearing age. So we're talking about risks of anti-seizure medications, etc. It comes up a lot, though, that the patient wants to know what is her risk of passing on JME to her offspring. So how do we counsel those patients regarding the risk of transmission?
So it's a complex genetic inheritance. The risk of transmitting to offspring can only be estimated based on a few studies. So there's variability, and they are not big studies with these numbers. So it's not like in the Mendelian fashion, like I said, you can estimate between 25 to 50%, but here it is really hard to give a percentage. One study, for example, showed an increased risk, which is different from percentage of offspring affected. So an increased risk of 12.5% in offspring of females with JME. And another interesting fact is that absence seizures in juvenile myoclonic epilepsy probands increase the overall risk of seizures in first-degree relatives by 15.8%, and that's from the same study.
And then just a follow-up to that, how do you know that your specific patient in front of you doesn't have the rare familial JME that would have a Mendelian inheritance? Do you need to do genetic testing for that, or do they even know what gene to test for?
Because we have so many patients with juvenile myoclonic epilepsy, they're not usually eligible for genetic testing, at least in Canada, for example. So what we have, because it's so rare to have the familial cases, where we usually don't investigate genetics in juvenile myoclonic epilepsy because it doesn't play a big role in to affect offspring. So the cases that we would usually investigate is when there is a strong family history in first degree relatives. So those are the ones that we would recommend genetic testing, and they are usually approved by our Canadian system, which is completely public. And then in the United States, I believe majority are also tested more in research studies, which is also what happens in Canada. So with genetic testing becoming cheaper, then there's a lot of research that would do whole exome sequencing, or even better, whole genome sequencing, which would be the best one to evaluate this complex inheritance. But even then, it's difficult because a lot of it is related to interpretation of this complex way of inheritance. So it really depends on who is interpreting or which part of the DNA you're looking at, because there are differences. The whole exome sequencing will only look at the coding DNA, it's a minority of the DNA. And in whole genome sequencing, we started looking at intronic mutations, which they were affecting the functionality of the genes. They can also affect expression.
Great. Thanks for explaining all that. And then just switching gears completely, can we talk also about Rett syndrome? Because this is another syndrome that is seen frequently. What are the genes involved for Rett syndrome?
Genetic testing became more available just recently because a lot of the cases that we would call idiopathic, majority became genetic epilepsy. So it's about 70% roughly. So with increasing accessibility and the reduced cost for testing, it's very important to understand how to order these tests or actually refer to a geneticist, because they are also open to interpretation and they can change the treatment. So in terms of Rett syndrome, it's usually caused by the MECP2 gene in the majority of cases, but there are also other genes involved that are more rare, and again, they were found more in research studies. So the fact that you test for Rett, and if you don't find the MECP2, which is X-linked, doesn't mean that patient doesn't have Rett. Actually, the diagnosis of Rett syndrome is clinical at first, and then you would move to genetic investigation.
I do adult epilepsy, so I often inherit patients from pediatric neurology clinic who have an unclear diagnosis, but it's presumed Rett's. That's the diagnosis they've carried for years. So why is it important to pursue accurate genetic testing in these patients?
So in the past, when genetic was found to be about 70% of the cases in epilepsy, a lot of physicians would question the utility of genetic testing because it's only a minority of patients that would actually, in where this would affect treatment. And then a lot of them are very disabled, so they wouldn't have necessarily offspring that would be affected. So they don't see that as very useful. And I've seen patients that came to me and they either genetic testing was never discussed or it was said that it's not useful at all, completely dismissed. But that's changing. So the importance of understanding the genetic diagnosis is that we know that it can improve outcomes in a lot of patients as we have more studies in genetics. It can also help comprehend the long-term prognosis, which is really important. So I have patients, for example, that will come to me, or in pediatric patients where they would ask, the parents would ask, what's the prognosis? Is my child going to have a long life? What are the limitations? Is the disease progressive? So in having that diagnosis, we have more information based on large studies or even small studies, and also can provide counseling for other family members. The other important key here, so when they come to an adult neurologist or epileptologist, what can be really strange to them is that later on they will develop motor deterioration, which is something that's being more studied recently. We've seen other syndromes like Dravet syndrome, which is a little bit more common. So it seems like later on, after this period of regression and stagnation, they will start deteriorating as if it was type of dementia. That can be really strange, and there can be a lot of investigations related to that, but that's actually a natural course of the disease, which again is important to know. When you do genetic testing, you actually understand that long-term outcome, and they can also develop spasticity or dystonia. And another important key is scoliosis. So we won't have necessarily all the symptoms, but understanding those will actually help in the suspicion. They can also have breathing difficulties, gastrointestinal problems are quite common. And also they are described to have small hand and feet that can be cold, usually with hypoperfusion. So one of the issues is that, like I said, some of these features can overlap with other syndromes, especially what we call now a group described as DEEs, or developmental epileptic encephalopathies, which basically encompass epilepsy, usually difficult to control, refractory, and intellectual disability, and developmental delay or regression or arrest. So another reason to get genetic testing is that there are studies showing these patients may respond better to certain medications. So it doesn't really make sense to deny patients genetic testing or say that it's not useful at all, which is something that is changing nowadays. So I'll give an example. Those patients have a lot of behavior issues with Rett syndrome. So if we give them certain medications such as prampanel and levetiracetam, we know they have a high probability of having side effects in behavior, so I usually avoid them. And more recently, there was an article with quite a few patients published by Oren Devinsky about the benefits of pure CBD oil, specifically Epidiolex, which is pharmaceutical grade type of CBD. So it's not any CBD that we have in the market, showing improvement not only in seizures, but behavior, spasticity, and sleep. And then the recent development about Rett syndrome is something that has been studied for many conditions. We have it, for example, for Dravet, and now we have genetic targeted treatment, which has proven not only to improve seizures, but also delay progression if it started early on, and increase quality of life in these patients. So it has become recently available in Canada, and in the US it has been available for a little bit longer. This is called trofinetide and is a synthetic analog of the amino-terminal tripeptide of IGF-1, which will treat those core symptoms of Rett syndrome. So that's one of the focus that has been happening in a lot of those conditions, because we usually target seizures, right? But sometimes seizures are controlled, and what happens is that what impairs their quality of life are the other core symptoms, such as behavior issues, sleep issues, gastrointestinal issues. So this medication could target all of that.
And that's only for the MECP2 genetic variant, is that right?
Yeah, so that's a great point that you mentioned. It is recommended only for MECP2 mutation. So for the rare cases where that's not available, it cannot be used.
Okay, so even if you had the all the features and you were pretty clinically sure that it was Rett, it could still be helpful to get the genetic testing because you'd have to identify that was the responsible gene in order to do the trofinetide.
Yes, but in the other rare cases, obviously, you would still get the other benefits like prognosis and even closure. I get a lot of families that would be like, oh, I was told this was an issue that occurred in uterus or when my child was born or during labor, it was a difficult labor. So, and they have a lot of guilt related to that. So that's also something that would remove that when we tell them it's genetic. They sometimes are really shocked and they're like, oh, I've been told for 30 years that this is the reason why my son or my daughter has this condition.
Yeah, I've seen that too, actually. And the genetic testing can be a big relief and alleviate some guilt in the parents. So then how do we differentiate CDKL5 deficiency disorder, which is CDD, from Rett, just clinically, according to their presentation?
So, and in the past, we used to call everything syndrome, and those patients with CDD were considered atypical, which is nowadays not correct concept. So with genetic testing, it was found that those patients have a different mutation, which is in CDKL5, which is X-linked. And the way you suspect that, as opposed to Rett, is that those patients usually have an early onset of the seizures at the age of 3 months, for example. They have severe developmental delay and intellectual disability from birth. A lot of them don't develop speech or gait. Seizures are usually easier to control in Rett, whereas in CDKL5, it is extremely difficult, and majority of them are actually refractory, and they are seen in epilepsy centers. So it's important to have that distinction in the genetics to understand that as well, because there could be a lot of frustration in terms of why are the seizures not improving. So the seizures start usually with infantile spasms, which is in about 80% of the cases, but you can also have tonic, myoclonic, tonic-clonic, atypical absence and focal seizures, which also doesn't help because they could put those patients initially in a group of West syndrome, which is when you have infantile spasms, so they won't necessarily investigate because there are so many genes. And then later on, because they develop so many seizures, they could also put them in a group of Lennox-Gastaut. Those patients can also have cortical vision disorders that Rett patients will not have, so they will have difficulties or even blindness. And the females with CDD are also more likely to have sleep disturbances. They are less likely to have breathing, scoliosis, gastrointestinal problems, or hand stereotypy. So those are some of the features that are better to understand. Unfortunately, we don't have genetic targeted treatments for CDKL5. There's some studies on cannabidiol, but again, it's a really difficult condition. And in refractory cases, you could try something palliative like ketogenic diet or a vagus nerve stimulator or a deep brain stimulator.
And then moving on to this subcortical band heterotopia and the periventricular nodular heterotopia. Sometimes these aren't even really considered as being genetic or X-linked inheritance. So can you talk a little bit more about those and how they are inherited?
First of all, there's a misconcept that focal epilepsies are not genetic. So a lot of times they are not investigated at all. And they would usually proceed more with the surgical investigations to get surgical treatments as they believe this is going to be more effective. So the subcortical band heterotopia and periventricular nodular heterotopia may have specific treatments, although because they can be very diffuse, bilateral, it's usually not common, and a lot of times they're not even investigated compared to other focal epilepsies, but specifically in periventricular nodular heterotopia with surgical investigation, sometimes intracranial electrodes are necessary. You can see that one nodule is the main generator of seizures, which could be targeted with less invasive procedures such as laser, and that could cause seizure freedom or a big improvement in seizure frequencies. The other importance of proper diagnosis is that in periventricular nodular heterotopia, we may have in a lot of these patients FLNA gene. and this can happen in males as well. And in both conditions, there could be associated symptoms that are important to know, such as connective tissue abnormalities, cutaneous and joint abnormalities, and other features of Ehlers-Danlos syndrome. And knowing these associations may lead to tests to investigate them and changing treatments as something that could be life-threatening, such as aortic aneurysm.
Yeah, that's great information. I actually didn't know that. And then how about the PCDH19 related epilepsy? That one doesn't have a nickname with it. It's just named after the gene. Are there any clinical pearls regarding that?
One of the main ones that was actually published a few years back by my mentor, Danielle Andrade, which is the senior author in this article, is that as much as it may resemble Dravet syndrome, it's onset with febrile seizures that are difficult to control. Actually, what she described was that despite being seizure-free, some of these patients may develop psychosis later on as adults, and then that could be something, is it related to the medication, such as levetiracetam, which is something very commonly used, and described even as first line for epilepsy in general. So I think that's a really important piece, and they would just need treatment for the psychosis, and it's usually not related to medication or the epilepsy per se, which may be controlled.
That's another great clinical pearl there. And then how about ACARDY? This one might be the easiest syndrome to recognize, but are there specific treatments available? And what is the actual genetics behind ACARDY syndrome?
It may be easier to recognize, especially nowadays that we do more investigations with brain MRI. But in the past, it was difficult because a lot of pediatricians would be afraid of recommending an MRI in infants or young children because they require general anesthesia. But there's a classic triad that's described, which is the agenesis of the corpus callosum, which would aid in the diagnosis of the MRI. But it could be a not complete agenesis. So it could be just the posterior or the anterior part of the corpus callosum. There's a series of matters related to that triad. Obviously, if you have all three, great, you're going to suspect the diagnosis. But like I said, sometimes the agenesis of the corpus callosum is not complete. So then they will think, that's just finding. And then the eye abnormality can be hard to diagnose because doing a fundoscopy in these patients is quite difficult, and they, again, may need some form of sedation or general anesthesia to access the fundus of the eye. And they can have other seizures that are not only infantile spasms. And also what I see a lot, because I see those patients as adults, sometimes 30 or 40 years old later, and back in the day, they would not investigate those patients with MRI. So sometimes I would ask, did your child ever had a MRI done? And they'll say, well, no, they had a head CT. There was nothing really. They could see a genesis of the corpus callosum, but then again, sometimes not complete. So some of the other features of ACARDY syndrome may be polymicrogyra or pachygyra, cerebral asymmetry. They can also have choroid plexus papillomas, ventriculomegaly, and intracerebral cysts. So it's a lot of manifestations that are usually not linked to ACARDY. So now we know that they can be present. So that all of that is confusing. So if you do have an MRI, sometimes they'll not suspect ACARDY. The other important piece is that they can have rapidly progressive scoliosis, and that doesn't respond to braces. So Rett syndrome, sometimes they'll put a brace, they'll recommend a brace, and that will help with the quality of life and progression of that and symptoms. But here, most studies say it doesn't help. So it's good to know that.
And what are the genetics involved with ACARDY? Or if we are suspecting that, should we pursue genetic workup?
There's no specific gene that has yet been found. So there's a lot of studies, even again, with whole genome sequencing. And there has been some rare monogenic genes identified. I'll just quote a few more common ones, like SCTH1, KMT2. There are many other ones that can be found in the original article, such as KMT2B, SLF1. But this was described only in a small group of 10 patients. So really, there's not a lot of information. We find with some of those rare syndromes is that if there's not a lot of patients, and there are multiple genes, it's really hard to put these as culprits. And then the targeted genetic therapies, they will actually not be investigated at all because it's such a small subset of patients, right? So it's not like Dravet, SCN1A, and then in red, the MECP2. In general, it's a syndrome that sometimes we won't investigate the genetics because, again, there's not a big role in that. And it's really rare to find something, especially because they're so rare. It will rarely modify treatment, whereas if you have that suspected clinical diagnosis, that could help knowing the long-term outcomes, closure, and all of that I spoke about before. And while most seizures are drug resistant, we do have some recent articles, again, in DEEs that this is also a part of. There's a lot of studies with CBD oil. So the other thing is ketogenic diet, and it has shown great benefits with a short-term success in one study. In 93% of the patients saw at least 50% seizure reduction as a palliative treatment. And the other main issue, just to finalize, is that a lot of these are not investigated for surgery. So in cases of iCardi, that could be something missed, I would say, because there's evidence for good outcomes. For example, when there's no complete agenesis of the corpus callosum, they could actually complete that corpus callosotomy, and that's a palliative treatment, but it helps in a way that the seizures may become less severe, less convulsive, because they may start in one area of the brain, and because there's no corpus callosum, they won't spread to the other side. So that will really help in the severity of those seizures and quality of life.
Thank you so much, Paula. I think genetics can be intimidating, so I love how you helped simplify all these syndromes for us. And there's a lot here that can be applied clinically right away. That was a lot of information, but don't worry because it's all covered in the published article by Paula and her colleagues. That article is titled Women with Genetic Epilepsies, and you can find that in the February 2025 issue of Neurology Genetics or online at neurology.org.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.